Welcome to this presentation on clinical practice guidelines for major depressive disorder. I am Liberty Olive Macias. I'm a psychiatric mental health nurse practitioner, and this recording was done in March of 2025. We will review key recommendations for assessment, treatment, and follow-up care for individuals with major depressive disorder or MDD. MDD is among the most common psychiatric disorders. Its proper diagnosis and management are crucial to reducing long-term disability and improving patient outcomes. A comprehensive psychiatric evaluation using DSM-5 criteria is essential to confirm a diagnosis and exclude other conditions such as bipolar disorder or medical causes. The diagnostic criteria for MDD in the DSM-5-TR include the following. Number 1, the symptoms. At least 5 of the following symptoms must be present during the same 2-week period, representing a change from previous functioning. At least one of the symptoms must either be depressed mood or loss of interest or pleasure. There should be depressed mood most of the day, nearly every day, markedly diminished interest or pleasure in all or almost all activities, significant weight loss or gain, or changes in appetite, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness or excessive guilt, diminished ability to think or concentrate, or indecisiveness, recurrent thoughts of death, suicidal ideation, or a suicide attempt. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The episode is not attributable to the physiological effects of a substance or another medical condition. Additionally, the occurrence of the depressive episode is not better explained by other mental health disorders such as schizoaffective disorder or schizophrenia. There has never been a manic or hypomanic episode unless it was substance-induced or attributable to a medical condition. The initial assessment for MDD typically includes key components such as patient's current symptoms, including their duration, severity, and impact on daily functioning, any history of depressive episodes, other psychiatric conditions, or substance use disorders. Psychosocial factors such as recent life stressors, support systems, and family history of mental health issues. We also use validated screening tools like the Patient Health Questionnaire or PHQ-9 to quantify symptom severity and monitor progress over time. We assess for suicidal ideation, self-harm, or harm to others. We also evaluate the presence of protective factors and any history of suicide attempts. We conduct medical evaluation to rule out conditions that could mimic or contribute to depressive symptoms such as hypothyroidism or vitamin deficiencies. Consider laboratory tests including thyroid function tests and a complete blood count if indicated. Then, we also want to determine the impact of symptoms on the patient's ability to work, maintain relationships, and perform daily activities. The history of antidepressants is a fascinating journey of discovery and innovation. The first antidepressants were discovered accidentally in the 1950s while researching treatments for other conditions. Monoamine oxidase inhibitors, or MAOIs, were initially developed for tuberculosis, but they showed mood-enhancing effects. But because MAOIs also cause hypertensive crisis when patients were eating certain foods, experts thought that there should be a way to treat depression by targeting monoamine receptors. Tricyclic antidepressants like imipramine were discovered during the search for antipsychotic medications. These strengthened the monoamine hypothesis in 1960s. However, the drugs were causing anticholinergic side effects and sedation and cardiac arrhythmias, so researchers began to focus on the role of serotonin in depression. This led to the development of selective serotonin reuptake inhibitors, or SSRIs, which became popular due to their improved safety profile compared to earlier drugs. The introduction of fluoxetine or Prozac in the 1980s marked a turning point. It was one of the first widely prescribed SSRIs and brought attention to the treatment of depression. Newer classes of antidepressants such as serotonin norepinephrine reuptake inhibitors or SNRIs and atypical antidepressants were developed to target different pathways in the brain. By the turn of the century, there were more antidepressants targeting the same neurotransmitters, but it was only around 2019 when the FDA approved a new antidepressants targeting glutamatergic pathway, which again was serendipitous following research on treatment for dementia. The evolution of antidepressants reflects ongoing efforts to improve efficacy, reduce side effects, and address the complexities of depression. The STAR*D study, or Sequence Treatment Alternatives to Relieve Depression, was a large-scale clinical trial funded by the National Institute of Mental Health published in 2008. It aimed to determine the most effective treatment strategies for individuals with major depressive disorder who do not respond to initial antidepressant therapy. The trial involved multiple levels of treatment, starting with the SSRI, citalopram in this case, and progressing to other medications or therapies if remission wasn't achieved. Some of the key impacts of the STAR*D trial was 1. Focus on remission, rather than just symptom reduction. This has shifted treatment goals in clinical practice. 2. Stepwise treatment approach. It has become a standard practice for managing treatment-resistant depression. 3. Augmenting antidepressants with other medications or combining them with psychotherapy like cognitive behavioral therapy or CBT. 4. By including diverse participants and focusing on practical clinical settings, STAR*D provided insights that are broadly applicable to everyday medical practice. The study's findings have informed treatment guidelines and encouraged clinicians to persist with treatment adjustments even after initial failures. So what is the stepwise approach? The stepwise treatment approach involves systematically adjusting treatments for depression when initial efforts do not lead to remission. Step 1. Start with a baseline treatment. Patients begin with a standard antidepressant such as an SSRI. This is monitored for effectiveness over a sufficient period. In the trial, the patients were monitored for 6 to 12 weeks on citalopram to assess the response and side effects. About 33% of participants achieved remission at this stage. Step 2. Switch or augment. If remission isn't achieved, the next step involves either switching to a different antidepressant or augmenting the current treatment with another medication or therapy, such as CBT. In the trial, for those who did not achieve remission, 2 paths were available. And the outcome? Remission rates increased to about 50% after this step. In switching, patients could switch to another antidepressant such as sertraline, which is another SSRI, bupropion, an NDRI, or venlafaxine, an SNRI. For augmentation, patients could add another treatment to citalopram, such as bupropion or buspirone. Third step, repeat as needed. This process continues through multiple levels, with each step offering alternative strategies. For example, after 2 unsuccessful trials, more complex combinations or medications from different classes may be introduced. Switch to another medication class, such as mirtazapine, which is a tetracyclic antidepressant, or nortriptyline, a tricyclic antidepressant. Combine treatments, such as adding lithium or thyroid hormone to the regimen. With the repeat as needed step, remission rates rose to approximately 60%. Switching to medications like a monoamine oxidase inhibitor or MAOI, or combining treatments with more complex regimens. And last step, persistence and monitoring. The approach emphasizes persistence, with clinicians closely monitoring symptoms and side effects to ensure treatments are given adequate time to work. This method ensures that patients receive tailored care, increasing the likelihood of achieving remission even in cases of treatment-resistant depression. The APA Clinical Practice Guidelines for the treatment of major depressive disorder provide evidence-based recommendations to assist clinicians in managing depression effectively. Guidelines stress the importance of a thorough evaluation, including a detailed history, symptom assessment, and consideration of co-occurring conditions. The guidelines recommend a range of treatments, including psychotherapy, pharmacotherapy, or a combination of both, tailored to the needs and preferences of the patient. Regular monitoring of symptoms, treatment adherence, and side effects is crucial to ensure progress and make necessary adjustments. The guidelines address considerations for specific groups such as children, adolescents, and older adults, ensuring treatments are age-appropriate and effective. For patients who do not respond to initial treatments, the guidelines suggest alternative strategies, including switching medications, augmenting therapies, or exploring advanced options like electroconvulsive therapy or ECT. Clinicians are encouraged to conduct a thorough assessment, including a detailed history of symptoms, medical and psychiatric history, and any co-occurring conditions. Tools like the PHQ-9 or Patient Health Questionnaire or the HAM-D Hamilton Depression Rating Scale are recommended for evaluating the severity of depression. It is vital to distinguish major depressive disorder from other conditions such as bipolar disorder or medical causes of depressive symptoms. We have mentioned diagnostic and screening tools. You may want to check on the Hamilton Depression Scale or the more common PHQ-9. The Montgomery-Asberg Depression Rating Scale, or the MADRS, is what researchers typically use for clinical trials. Initial medication selection is individualized. Monitoring for side effects and early signs of improvement is recommended in the guidelines. We need to document this. For first-line pharmacotherapy, preferred agents are SSRIs, SNRIs, bupropion, or mirtazapine. How do we pick the medication for our patients? Some of the selection factors are symptom profile, side effect tolerability, and comorbidities. Response typically occurs by 4 to 8 weeks. Treatment intensity should match the severity of the illness. Shared decision-making with the patient is vital. For treatment planning, mild to moderate MDD, psychotherapy alone or with pharmacotherapy. For moderate to severe MDD, a combination of pharmacotherapy and psychotherapy is recommended. For treatment-resistant depression, consider ECT, TMS, or ketamine or esketamine. Treatment planning during the acute phase. Individuals who do not experience full relief from depressive symptoms should continue with treatment during the acute phase, as ending this phase prematurely may lead to poor functional outcomes. If moderate symptom improvement is not observed within 4 to 8 weeks of starting treatment, clinicians should reevaluate the diagnosis, assess side effects, review any co-occurring conditions or psychosocial factors, and adjust the treatment plan accordingly. For those undergoing psychotherapy, factors to consider include session frequency and whether the therapeutic approach aligns with the patient's needs. When medications are prescribed, psychiatrists should assess pharmacokinetic and pharmacodynamic factors to determine whether dose adjustments are needed. For certain antidepressants, like TCAs, drug blood levels can help guide dose modifications. If, after another 4 to 8 weeks of treatment, minimal or no improvement is noted, further investigation into contributing factors and adjustments to the treatment plan should be undertaken. Consulting a specialist may be appropriate. For patients on antidepressants, optimizing the dose is often the first step if side effects are manageable and the maximum dose has not been reached. For those who show limited improvement or experience significant side effects, alternative strategies include combining antidepressants with depression-focused psychotherapy, switching to another non-MAOI antidepressant, or augmenting the current regimen with a non-antidepressant medications. Changing to an antidepressant within the same pharmacological class, such as switching from one SSRI to another SSRI or to a different class like SSRI to a TCA, are viable options. Patients who do not respond to SSRIs might benefit from trying an SNRI. I have added recommendation on switching antidepressants in the appendix section of this presentation. Augmentation can involve combining antidepressants from different classes or incorporating non-antidepressant agents like lithium, thyroid hormone, or second-generation antipsychotics. Other options with less established evidence include using anticonvulsants, omega-3 fatty acids, folate, psychostimulants like modafinil, or medications targeting anxiety or insomnia such as buspirone, benzodiazepines, or selective GABA agonist hypnotics like zolpidem or esopicolone. For patients whose symptoms persist despite pharmacological treatments, ECT remains the most effective option. Other possibilities include switching to non-selective MAOIs with careful adherence to dietary and medication restrictions, or using transdermal selegiline, which has fewer restrictions. Transcranial magnetic stimulation, or TMS, and vagus nerve stimulation like VNS may be considered for patients who have not responded to multiple adequate treatment trials, including ECT. For psychotherapy-only patients, intensifying treatment or transitioning to a different therapeutic approach may be necessary. If psychotherapy alone proves insufficient, adding or substituting pharmacological treatments should be evaluated. Patients with a history of incomplete responses or poor adherence to single treatment modalities may benefit from a combined approach. Treatment planning during the continuation phase. Patients who respond positively to ECT are advised to continue treatment with medications, with a combination of lithium and nortriptyline being particularly recommended. Alternatively, continuation ECT can be employed, especially in cases where medications and psychotherapy have not effectively maintained remission. During the continuation phase of treatment, careful monitoring is important to detect any signs of relapse. This involves systematic assessments of symptoms, side effects, treatment adherence, and overall functional status. To reduce the likelihood of relapse, patients who achieved success with antidepressants during the acute treatment phase should continue using these medications for an additional 4 to 9 months. Typically, the same dose from the acute phase is maintained in the continuation phase. Additionally, depression-focused psychotherapy is recommended to prevent relapse, with cognitive behavioral therapy having the strongest evidence of effectiveness. Treatment planning during the maintenance phase. Patients who have experienced 3 or more episodes of major depression or have chronic major depressive disorder should transition to the maintenance phase of treatment following the continuation phase. Maintenance therapy is also recommended for individuals with additional recurrence risk factors such as residual symptoms, persistent psychosocial stressors, early onset of depression, or a family history of mood disorders. Other considerations for maintenance therapy include patient preferences, previous treatment types, side effects, experience during continuation therapy, severity and frequency of past depressive episodes, including psychosis or suicidal tendencies, and the persistence of depressive symptoms after initial recovery. Many individuals, especially those with chronic and recurrent depression or coexisting medical or psychiatric conditions, may require indefinite treatment. Monitor a patient regularly in maintenance phase to mitigate the risk of recurrence. Antidepressants that effectively achieved symptom remission during the acute phase and maintained remission through the continuation phase should be carried forward at the same therapeutic dosage. Depression-focused psychotherapy utilized during prior phases should also be considered in the maintenance phase, possibly with reduced session frequency. For patients whose depressive episodes have previously not responded to medications or psychotherapy but have improved with ECT, maintenance ECT may be an option. Vagus nerve stimulation or VNS is another possible treatment for individuals who responded positively to this modality during earlier phases. Maintenance and relapse prevention. Relapse is common. Long-term management includes ongoing support, education, and treatment adherence. Systematic and regular patient evaluations during the maintenance phase must be carried out to address the risk of recurrent depressive episodes. Using standardized measurement tools can help detect early symptoms of symptom recurrence, ensuring timely intervention and optimal care. When discontinuing pharmacotherapy, taper the medication gradually over several weeks to months to minimize the risk of discontinuation symptoms. Patients should be advised against stopping medications abruptly and reminded to keep their medications accessible, particularly when traveling or away from home. Implementing a slow taper or temporarily switching to a longer half-life antidepressant can further reduce the likelihood of discontinuation syndrome during dose reduction or medication withdrawal. Before ending active treatment, patients should be informed of the potential for depressive relapse and assisted in establishing a plan to seek help if symptoms recur. Following medication discontinuation, patients should remain under close monitoring for several months. If symptoms reappear, another course of acute phase treatment should be initiated promptly. For psychotherapy patients, discussions about ending treatment should begin well in advance of the final session, although the specifics of this process may vary depending on the type of therapy utilized. This ensures a smooth transition and addresses any concerns related to treatment discontinuation effectively. For suicidal patients, we should increase the intensity of treatment, which may include hospitalization if necessary, or combining pharmacotherapy with psychotherapy. Factors influencing treatment intensity include the quality of the doctor-patient relationship, availability of social support, access to and lethality of suicide methods, co-occurring substance use disorders, and personal or family history of suicidal behavior. For patients experiencing psychotic symptoms during major depressive episodes, treatment should involve a combination of antipsychotic and antidepressant medications, or ECT. Cognitive dysfunction during a depressive episode should be systematically assessed, as it may indicate an elevated risk of future dementia. Catatonic symptoms in depression should be treated with benzodiazepines or barbiturates, often in combination with an antidepressant. If symptoms persist, ECT is recommended. Supportive medical care may also be necessary to prevent complications such as dehydration, malnutrition, deep vein thrombosis, or contractures. When using antipsychotic medications, monitoring for neuroleptic malignant syndrome is essential as patients with catatonia may be more susceptible. For individuals with co-occurring psychiatric disorders, both conditions should be addressed in the treatment plan. Benzodiazepines can be used adjunctively in patients with depression and anxiety, though careful monitoring is required in those with substance use disorders. For smokers, bupropion or nortriptyline may treat depression while supporting smoking cessation. A period of substance abstinence can help determine whether a depressive episode is substance-related, although a family or personal history of major depressive disorder may necessitate early antidepressant intervention. In patients with both major depressive disorder and personality disorders, psychiatrists should prioritize treatment of depression while also considering psychotherapy and adjunctive pharmacotherapy for managing personality disorder symptoms. Psychotherapy is effective for many patients, especially those who prefer to avoid medications or have contraindications. Non-pharmacological interventions may also be helpful in relapse prevention. Special populations. Treatment should be tailored to the individual's age, pregnancy status, and other medical factors to optimize outcomes and reduce risks. For the adolescents, antidepressants carry a black box warning about increased risk of suicidal thoughts and behaviors, particularly during the initial weeks of treatment. We need to closely monitor them. Fluoxetine and escitalopram are the only antidepressants approved by the FDA for use in adolescents. Other antidepressants may be used off-label but require careful evaluation of risks and benefits. Cognitive behavioral therapy or CBT is often recommended as a first-line treatment or in combination with medication. Untreated depression during pregnancy is associated with a higher likelihood of preterm birth and low birth weight infants. However, treating depression has not been shown to significantly improve these outcomes, and SSRIs may independently contribute to an increased risk of preterm birth. Screening for depression among pregnant and postpartum individuals can reduce the absolute risk of depression by 2 to 9% at 3 to 5 months, regardless of treatment. The U.S. Preventive Services Task Force recommends that clinicians offer or refer those at higher risk of perinatal depression to counseling interventions. For patients already taking antidepressants prior to pregnancy, discontinuation is more likely to result in relapse when the depression is severe or recurrent. Continuation of antidepressants is recommended when the risk of relapse outweighs the potential for rare neonatal complications based on shared decision-making. SSRI use in the third trimester may heighten the risk of neonatal respiratory distress, tremors, and NICU admission. However, discontinuing SSRIs in the third trimester does not improve these outcomes, and there is no data on long-term neurocognitive effects. The FDA advisory on SSRI use during pregnancy highlights conflicting findings regarding persistent pulmonary hypertension in newborns. For breastfeeding patients, antidepressants are transferred into breast milk at low concentrations, with paroxetine and sertraline resulting in undetectable levels in infant plasma, while fluoxetine and venlafaxine produce higher concentrations. Rare case reports, particularly involving fluoxetine and citalopram, have noted nonspecific effects in infants such as irritability and reduced feeding. For the elderly population, there is data of higher response rates with quetiapine, mirtazapine, and duloxetine compared to placebo. Quetiapine carries a boxed warning from the FDA due to increased mortality risk in older patients with dementia-related psychosis. In this population, assessing and reducing fall risk is critical, as untreated depression and antidepressant use can both contribute to falls. Since older adults face a higher risk of adverse drug reactions, treatment is often started at about half the typical adult dose. Guidelines recommend sertraline, duloxetine, or escitalopram as preferred first-line options. Bupropion, mirtazapine, and venlafaxine are suitable alternatives due to their favorable side effect profiles, while paroxetine and fluoxetine should be avoided due to their association with anticholinergic effects, agitation, and overstimulation. Before initiating SSRIs or SNRIs, we should screen for a history of hyponatremia and monitor serum sodium levels 2 to 4 weeks after starting therapy. Treatment-resistant depression. For patients who do not respond to standard treatments, options like ECT, TMS, or ketamine-based therapies may be considered. Stepwise approach. Persistence and systematic adjustments are emphasized to achieve remission. In conclusion, with proper diagnosis, intervention, and follow-up, patients with MDD can experience significant improvement in their quality of life. These guidelines provide a comprehensive framework for clinicians to deliver personalized, evidence-based care for individuals with depression. You can explore more details on the APA website. These are the references for this presentation. This is an algorithm practice guidelines that you can review. These are comprehensive but not exhaustive lists of antidepressants. They do not include the most updated antidepressants in the market today. Table 2 also shows the comparative risk of antidepressant discontinuation syndrome for selected antidepressants. And Table 3 is tapering strategies for antidepressant medications. This is a guide on switching antidepressants that you can use as reference. And lastly, this is a summary of antidepressant dosing, which includes the risk of discontinuation syndrome. To date, there are no validated formal schedules for tapering antidepressants, but the principle slower is better is widely accepted. Many experts agree that tapering over at least 14 days can lower the risk of discontinuation symptoms compared to shorter tapers lasting 1 to 10 days. Current recommendations suggest adjusting antidepressant doses every 1 to 4 weeks, tapering over 3 to 4 months. The 10% rule, which is reducing the dose by 10% weekly, has been suggested as a gradual approach. Switching to liquid formulations may aid slow tapering by allowing precise dosing, though paroxetine and venlafaxine, which are commonly linked to antidepressant discontinuation syndrome, are not readily available in liquid form. Patients often resort to dividing capsule contents or cutting unscored tablets to achieve gradual dose reduction. Custom formulations prepared by compounding pharmacies can also be used to support tapering strategies.